So, hello, welcome to another lecture series of in Hematology 1. We will discuss today WBC pathologies. I have divided the topic into two. So, first, discuss natin yung non-malignant type of disorders. So, under this category, we will discuss quantitative. Ano ang ibig sabihin ng quantitative? May problems regarding numbers. Qualitative naman, may problems tayo sa morphology or the function of the WBC or parehas. Okay? Sa second part ng ating lecture, we will discuss the malignant type or the cancerous types of leukocyte disorders. Under this classification, may pag-uusapan natin yung mga classification of leukemias and lymphomas. Okay. Unahin natin mga quantitative abnormalities. Okay? So, before we proceed with abnormalities in numbers, kailangan alam nyo din kung ano yung mga normal values. And again, we will go back to our favorite mnemonics, never let monkey eat banana. So, ano ibig sabihin? Neutrophils are the most abundant WBC in the bloodstream, and yung basophil naman ang least abundant pagdating sa PBS. Okay? And anything ng derangement na dyan will interpreted as a disorder. Halimbawa, may neutrophilia, ibig sabihin may bacterial infection, lymphocytosis, ibig sabihin may viral infection as well. So this slide is an additional note, no? So please take note of the following table. These are the terminologies used to describe the quantitative derangement of each WBCs. So halimbawa, no, neutrophils. Mataas na level of neutrophils, ang term natin dyan is neutrophilia. Okay? Mababang levels of neutrophils, ang term natin dyan is neutropenia. But in some other cases or books, ang term nila doon is agranulocytosis. So, wag tayo magpapalito, ha? Agranulocytosis is synonymous with neutropenia. So, discuss naman natin yung mga different conditions causing this derangement. So, halimbawa sa neutrophilia, your neutrophils is expected to be increased in all bacterial infection and during acute phase of inflammation. Okay? Sa neutropenia naman or bagsak na neutrophils, dito natin ma-correlate si typhoid fever. No? Back in your bacteriology, typhoid fever is caused by Salmonella typhi. Measles and influenza are viral infection naman, which primarily targets WBC, most especially neutrophil. So, mababa yung levels of your neutrophil in your peripheral blood. Next terminologies, derangement in your lymphocytes. Kapag mataas na lymphocytes, ang term natin doon is lymphocytosis, mababang lymphocyte, lymphopenia. Okay, ano naman yung mga associated conditions under each derangement? Kapag mataas ang lymphocytes, it is most probably caused by viral infection or kung ang pasyente mo ay nasa chronic phase of inflammation. Lymphopenia naman, kapag ang pasyente mo ay nasa acute phase of infection or inflammation, or yung mga patient na nag-undergo ng irradiation therapy, and this type of treatment is being done to patients with cancers. Okay? So, halimbawa, no, trick question sa mga board exam centers, lagi nila tinatanong to. Ano ang mataas na type of WBC in cases of acute appendicitis. So, appendicitis is the inflammation of your appendix. So, nasa acute phase siya. So, ano ang answer doon? Neutrophil. Okay? So, next three WBCs naman tayo. Sa mga monocytes, no? Increased levels of monocytes is associated with either tuberculosis or malaria. So, napapansin nyo, no, wala tayong masyadong associated the condition sa mga mabababang levels of your monocyte, eosinophils, and basophils. In some books kasi, pwede na 0% sila in your peripheral blood smear. No? Pwede natin silang i-consider as normal kahit 0 sila or absent, total absent sila sa inyong PPS. Next naman, eosinophils, associated yan with your asthma attacks, hypersensitivity reaction. Ano ibig sabihin ng hypersensitivity reaction? Ito yung mga rashes, yan, namamaga yung mata, okay? Nagkaroon kayo ng drug interaction. Ang mataas dyan is yung eosinophil. And huwag natin kakalimutan din yung ating mga parasitic infections. Basophils, again, no, same as eosinophil, tumataas din sila in cases of hypersensitivity reaction. So, other additional terminologies naman tayo. Ito, nandiyan na yan sa handouts nyo. So, we have two types of counting WBC types, no? Meron tayong absolute counting and relative counting. So, in clinics, pinakamadalas na kino-compute is yung absolute neutrophil count. Lalong-lalo na, no, in cases of patients undergoing antibiotic treatment, no? Kunyari, hindi nagre-react yung pasyente sa antibiotic kahit sobrang lakas na. So, ano kayo ang problem? Baka hindi sa antibiotic. Baka mababa yung levels ng panlaban na WBCs ng pasyente. And most, di ba sabi natin, the most associated or most commonly linked with acute infection is neutrophil. So, ito yung madalas na ginagamit. So, paano kino-compute itong absolute neutrophil count? So, we take into consideration the numbers of your neutrophils and the percentages of your band cells. Okay. And again, no, bisitahin natin yung term na agranulocytosis. Ano ulit ang synonym term niya? No? Ito ay neutropenia. Pero in agranulocytosis, the difference between neutropenia and agranulocytosis is that agranulocytosis must meet a criteria or meron dapat siyang required level. So, anong level of your absolute neutrophil count mo masasabi na may agranulocytosis yung pasyente? Dapat less than 0.5. Okay? General term si neutropenia, pero si agranulocytosis mas specific kasi meron siyang require na specific na level of your absolute neutrophil count. Next terminology naman natin is yung leukoerythroblastic reaction. So, ihimay natin itong term na to, no? Leuko means WBCs, erythro, RBC. Pero anong type of cells ba? Mature or immature? Immature yan kasi we are talking about the blasts. Diba? Sa ating histology, yung mga blasts ay mga babies. Ang cytes, CYTE, yun yung mga mature. So, when we talk about this term, ang ibig sabihin nito, no, there is a reaction, no, an increased reaction of your immature neutrophils, no, leuko, di ba, WBC, and then increased number of your nucleated red blood cells, okay? Ano ibig sabihin ng nucleated? Di ba, ang RBC, para masabi mo na mature siya, dapat wala siyang nucleus. Kapag may nucleus pa yan, Ibig sabihin, baby pa yan. And a type of your RBC anomaly, which is specific tayo dapat dito, teardrop RBCs. Ano ang ibang term for teardrop RBCs? This is also called as dacrocytes. And leukoerythroblastic reaction is commonly seen in patients suffering from myelofibrosis or in other books, no, primary myelofibrosis. So, di-discuss natin yan mamaya. Okay? And then last for our terminologies is leukemoid reaction. So, tingnan natin yung term, leukemoid. Diba pag ina-add natin yung OID sa suffix niya, ibig sabihin parang may pagka-leukemia siya pero hindi talaga siya totally leukemia. So, tinawag na leukemoid. So, bakit kaya ito yung term na yon? Kasi in this type of reaction, no, meron tayong excessive production of your WBCs above 50 pa nga, no? And with marked shift to the left. Ano ibig sabihin ng shift to the left? No, hindi left side ng PBS or ng smear nyo. Ibig sabihin ng shift to the left, no? Discuss lang natin. So pag sinabi nating left shift or shift to the left, no, mas marami yung bilang ng cells na immature or nasa left side of the maturation lineage. Okay? Kapag sinabi natin shift to the right, mas marami naman yung mature, no, in relation with the numbers of your immature cells. So, ganon ang tamang usage of the term. So, ayun na nga, no? Leukemoid, madaming cells, katulad siya ng leukemia. Pero anong difference ng leukemoid and leukemia? Leukemia, sabi nga natin kanina, malignant type siya or cancerous type siya. Ibig sabihin kasi nung cancer, no, balikan natin yung histopath natin, hindi sinusunod yung tamang cell cycle. Kaya walang masyadong namamatay or hindi nag-undergo ng apoptosis ang mga cancer cells. Dumadami sila on its own, no? May pagka-immortality yung characteristic ng cancer cell. While in this reaction, no, leukemoid reaction, walang ganon na nangyayari. Normal pa rin yung cell cycle, madami lang talaga yung napoproduce na WBCs. Okay, practicing nga natin gawin yung absolute neutrophil count. So again, no, ang absolute neutrophil count natin, we take into consideration the levels of your neutrophils and the percentages of your band cells. Okay? So paano ang formula dyan? Kunin mo yung information regarding the WBC count, multiply by the decimal part of the percentages of your neutrophil and band cell. So, makikita mo yan sa iyong CBC result, no? So, for example, no, our given information, the WBC is 10 times 10 raised to the 9th power, neutrophil is 60%, bands is 5%. So, paano mo yan gagawin? Kukunin mo muna yung mga absolute numbers, no? And then, for neutrophil and band cells, dapat naka-decimal format siya. So, yan yung ating characteristic number 10 multiply by ano ang decimal part nitong 60%? 0.6 plus 5%, 0.05. So, add natin itong munang dalawa, no? So, magiging 0.65 multiply by 10. So, magiging 6.5 times 10 raised to the 9th power per liter of blood. So, ito na yung absolute counts natin. Pero hindi lang dyan natatapos, no? Kailangan ma-interpret mo siya. So, tuwing kailan ginagamit si absolute neutrophil count if you want to determine if there is agranulocytosis. For this example, meron ba siyang agranulocytosis? Wala. Okay? Kasi ang cut-off natin is less than 0.5. Then next, leukemioid reaction versus CML. CML is chronic myelogenous leukemia. Then again, no, sinabi ko nga, leukemioid from the term itself, mukha daw siyang leukemia. And ang pinakamalapit na type of leukemia na kamukha ng leukemioid reaction is your CML. Pero paano natin ma-differentiate itong dalawa? So we have 4 criteria, no? Unang-una, ano ang dumadami ba? Ano bang type of leukocyte ang predominant in each of this condition? Kapag leukemioid, ang mataas lang dyan is neutrophils and band cells. Whereas in CML, lahat ng pati blast, no? Pati mga mature cells dumadami din in CML. Ano ulit ang cut-off natin dun sa CML as compared to your AML? Ano ang blast number? Diba kapag acute, more than 20%. Ang chronic, less than 20%. Okay, next criteria naman, ang mga platelet counts natin. Leukemioid reaction, normal ang platelet count. Sa CML, high ang platelet count. Okay? Kasi one of the problem with CML, yung ating bone marrow. Okay? So, pati yung platelet count, madami din. Next naman, ano tong PH1 na to? PH1 is also known as your Philadelphia chromosome. So, saan meron lang may Philadelphia chromosome? Yung CML. Negative sa leukemioid reaction. And lastly, pakibilugan, no? Must know ito. The lab score between your CML and leukemioid is also different. Leukemioid reaction, ang lab score is high. Ang lab score naman sa CML, low. Okay? Bakit kaya ganito ang results nila? So, discuss natin yung lab. Okay, LAP is also known as leukocyte alkaline phosphatase test. And this enzyme is commonly seen in neutrophils lang with normal growth. Okay, ano ibig sabihin ng normal growth? Ibig sabihin hindi sila dumulundag ng differentiation, no? And sumusunod sa tamang cell cycle. Unlike sa mga leukemia and malignant cells, hindi nasusunod yung cell cycle. So, mas makikita ngayon ang lab activity sa mga normal cells as compared sa cancer cells. Kaya mas madami ang lab score or mas malaki ang lab score sa leukemioid as compared to your leukemia. Okay? And the staining technique used in lab scoring is what you call the Kaplan method. Kaya may makikita kayo na instead of lab scoring ang term, Kaplan method ang nilalagay nila sa question. So, parehas lang itong dalawang ito. Okay? And ano ba ang normal range ng lab score para masabi natin kung increase or decrease? The normal score is 20 to 100. Less than 20, CML. More than 100, leukemioid reaction. So, paano ba ginagawa itong Kaplan method? So, meron tayong grading system na yan. And objectively lang natin nilalagyan ng grade based dun sa criteria na to. Okay? Mas intense yung color of the cytoplasm or the granules, mas malaki yung number or the grade of the cell. So, anong unang step na gagawin ng medtech in lab scoring? Magbibilang yan ng 100 WBC, okay? And then, i-grade bawat isa according to their intensity of the color. So, halimbawa, itong case na to, no? Nakapagbilang si medtech ng 100 WBC, and bawat WBC ginrade niya according to the intensity of the granular color. Okay? And then, imumultiply niya yan. Halimbawa, 0 times 52. So, may 52 WBCs na may 0 grade. Okay, so 0 yan. 1 plus 20. So, 1 times 20, 20. Okay, 2 times 16, 32, and so on. So, i-add ni medtech yan, and the final number will be the lab score or the Kaplow score. So, interpret natin to, is this normal, leukemoid, or CML? Normal ang lab score, so hindi yan leukemoid and hindi rin yan CML. So, ganito ginagawa ang lab scoring. Next, this group of conditions will produce increased number of WBC counts. Itong mga group of conditions na to ay tinatawag na myeloproliferative neoplasms. Proliferative, ibig sabihin madaming-madaming cells sa bone marrow. Okay? And then, actually, itong mga group of condition na to is also considered as cancerous dahil hindi nila sinusunod yung tamang cell cycle, causing the proliferation of the cells. What are the causes or the pathophysiology of your myeloproliferative disorders? Number 1, hypersensitivity to hormones or growth factors. Halimbawa lang, no, hypersensitive ang bone marrow mo sa erythropoietin. Erythropoietin is a hormone that induces erythropoiesis or RBC production. Kung halimbawa na kahit nasa mababang levels lang yung EPO mo, if overreacting si bone marrow, it will produce a lot of RBC kahit hindi pa kailangan. And then the number 2, independence. Ano ibig sabihin nitong independence na to? Ibig sabihin, hindi kahit walang mga hormones for blood production, kaya na mag-produce on its own nung bone marrow, which is a bad news kasi kailangan ng regulators, no? Kailangan may magpapa-initiate, kailangan din may magpapa-suppress. Pero in this manner, kung may independence, walang nagsusuppress or nag-regulate ng blood cell production. Okay, we have 4 types or classification of these disorders according to WHO. So, unahin natin itong CML. CML is, again, chronic myelogenous leukemia. So, ano ang mas nagpo-proliferate na cell pagdating dito sa type of condition? Siyempre, yung mga leukocytes or WBCs. Next naman is PV, polycythemia vera, or in other books, polycythemia vera leukemia. No? This type of condition, ano naman ang mas nagpo-proliferate? Siyempre, yung ating RBC. Okay? Okay. ET is again, paki-correct, essential thrombocythemia yan. And then, ano naman ang type of cell na mas dumadami in ET? Your platelets naman. Okay? Sa PMF or your primary myelofibrosis, lahat ng blood cells madami. WBC, RBC, platelet, plus fibroblast. Kasi meron, based sa name ng condition, myelofibrosis, so madami rin siyang fibrin or fibroblast. And according to WHO, merong common denominator lahat itong myeloproliferative neoplasm, which is the genetic mutation of JAK2 mutation. Pero may exception tayo dyan. Lahat ng myeloproliferative neoplasm has JAK2 mutation except your CML. So, paki-take note yan. Okay. Pag-usapan natin ulit si chronic myelogenous leukemia, or in other books, chronic granulocytic leukemia. Ang mean age of the patients having this kind of condition is 50 years old. So, masasabi natin na pang-elderly itong type of leukemia na to. And again, it has genetic mutation called Philadelphia chromosome. Sa Philadelphia chromosome, meron tayong transposition of your chromosome 9 and 22, causing your fusion of ABL and BCR gene. So, paano ginagamit yan in clinics? Actually, nagre-request lang nito to identify if the patient has a good prognosis or bad prognosis. The presence of your Philadelphia chromosome will dictate na merong good prognosis yung patient. Hindi siya ginagamit as pang-diagnose. Sa peripheral blood smear naman, makikita mo, no, madaming granulocytes, kaya nga siya tinawag na chronic granulocytic leukemia, with blast accumulation of less than 20%. Kapag nag-more than 20% na yan, mako-convert na yung chronic myelogenous leukemia mo into acute myelogenous leukemia. So, ang cutoff is 20. And again, wala tong JAK2 mutation. Recall din natin, no, 'di ba, ang CML kamukha niya ang leukemoid reaction. And ang easiest way to differentiate these two is through reviewing the peripheral blood smear and gagawa ka ng CAPLO or LAP scoring. LAP score in leukemoid reaction is high, LAP scoring in CML is low. Again, kanina di ba nabanggit ko yung cut-off natin between chronic and acute leukemia. Di ba dapat 20%. So, in cases of yung CML mo, dumami yung kanyang blast to more than 20%, ang tawag na doon is blast crisis. And blast crisis leukemia can be converted into AML and ALL. So, ang magpapalito ha, ang blast crisis converts your CML into AML or ALL. So, depende kung ano ang dumami na type of blast. Kung ang dumami na type of blast is myeloblast, so magiging AML, lymphoblast naman for ALL. Next naman, polycythemia vera. Pathophysiology niya, again, di ba, same din yan. Hypersensitivity to erythropoietin by the bone marrow and independence of your bone marrow to erythropoietin. Ibig sabihin, hindi na niya kailangan ng erythropoietin to produce RBC, which is, again, a bad thing. So next, paano natin i-diagnose yung PV or polycythemia vera? It has to be, yung patient has 2 major criteria plus 1 minor criteria. So kailangan meron siyang increased hemoglobin levels plus your JAK2 mutation, okay? And one of these minor criteria. Panmyelosis. Anong ibig sabihin ng panmyelosis? Pan means all. Okay? So, lahat ng cells in the bone marrow, madami. Bone marrow tong BM. Okay? And then, decreased EPO levels. EPO is erythropoietin. Or, meron siyang erythroid colony formation in vitro. So, ibig sabihin, kahit nasa labasan ng katawan, no, walang erythropoietin in the test tube, meron pa rin production or ongoing RBC production. So next is essential thrombocythemia, no, or ET. In some books, ang term is essential thrombocytosis, pero same lang din sila. Anyway, so based on WHO, ang cut-off ng ET is above 450. Pero in your books, sa RODAX, ang cut-off for your ET is 600. So, basahin nyo na ng mabuti ang ating question, yung questionnaire nyo, kung alin ang basis for your ET. Okay? And then, Ano naman ang bad thing then with ET? Aside from thrombocytosis, the platelets being produced are dysfunctional or hindi naman nagpe-perform ng hemostasis. Okay? So, meron ka ng thrombotic episodes, meron ka pang bleeding episodes. So, it's a bad condition. And again, may JAK2 mutation ang ET. So, balikan natin ulit yung criteria natin for ET. So, magkaiba yung WHO and RODAX criteria. Sa RODAX, again, above 600, plus, ang hemoglobin mo dapat is less than 13 with stainable iron in the bone marrow. Sa WHO, mas marami ang kanyang criteria. Number 1, dapat above 450 ang platelet count. Ang bone marrow mo naman, kailangan megakaryopoiesis activity lang ang na-appreciate. Okay? Number 3, no myelodysplasia. Ano ibig sabihin ng myelodysplasia? Yung incorrect differentiation of your bone cells, bone marrow cells. So, kailangan nasusunod pa rin yung tamang maturity of the blood cells. And lastly, the JAK2 mutation. Okay, lastly, yung last condition sa myeloproliferative neoplasms natin is primary myelofibrosis or PMF. Dito naman, again, madami lahat ang cells plus your fibroblasts. So, tingnan natin, madaming leukocytes, tama? Madaming RBC in the form of dacryocyte, and madaming platelet at the level of megakaryocyte and fibroblast, which is the basis of the name, kaya myelofibrosis. And then another important to take note is the ultimate complication of your PMF, which is the splenomegaly or enlargement of the spleen. So ano ang pathophysiology of enlargement of spleen in PMF? Number 1, so since madaming cells, so marami din ang mga namamatay. Okay? So, sino ba yung organ na kumakain ng mga dead or senescent cells? Yung ating spleen. So, meron tayong increased sequestration or increased increased size of spleen dahil madaming kinakain na old cells. And then next is extramedullary hematopoiesis. Ano ibig sabihin ng extramedullary? Outside the bone marrow, yung bone cell production. Bakit pa nagkakaroon ng outside bone marrow? Sobrang OA na yung bone marrow mo in producing cells. Kasi ganito yan, itong mga cells na pinoproduce ng bone marrow mo, very defective. Okay? So, kailangan mag-adjust ng katawan mo to produce bone cells which are functional. So, hanap siya ng mga organs na kaya mag-produce ng mga functional bone cells such as your spleen. Kaya, meron ding enlargement ng spleen. Okay, next group of disorders are your qualitative disorders. And these include, number 1, may mali sa itsura or the morphology, or may mali sa action or the function of the cell. And sa madalas na event, pwedeng both of the morphology and function are deranged. Okay? So, unahin natin sa mga qualitative WBC disorder is the Pelger-Huet anomaly. So, ano meron sa Pelger-Huet? There is a decreased segmentation of the nucleus or tinatawag natin hyposegmentation. Ilan ba dapat ang segment ng nucleus ng mga WBC? So, supposedly dapat 2 to 5. Okay? Less than 2 or equal to 2, ang itsura niya ngayon, mukhang peanut shape, or pince nez morphology. Ang tinatawag natin bilobe morphology. So mamaya pakita natin ano ba ibig sabihin ng pince nez. And then in other WBCs, ma-appreciate mo din na kokonti yung kanilang granulation due to clumping. Nagsasama-sama na. Okay? Tinatawag nating hypogranulation. So in Pelger-Huet, no, tandaan natin there is hyposegmentation and hypogranulation. Okay, and then Pelger-Huet is also a genetic disorder. It affects the lamin B receptor gene, which is responsible for the morphology, specifically with the neutrophils. Okay. Ano ulit yung pince nez? Yung pince nez is actually an old man's glasses, no? Ito yung type of dust na tinatawag natin pince nez. So, mukha daw siya lang pince nez. Ito, lalo na dito. Ito naman mukhang peanut shape. Nawalan ng segmentations. Actually, isang segment lang ito. Itong buong ito. Okay, we have true versus pseudo. Pseudo means false. So, mukha lang siyang Pelger-Huet, pero in actuality, hindi talaga siya Pelger-Huet. So, paano mo ma-differentiate ngayon yung totoong Pelger-Huet versus the pseudo Pelger-Huet? Okay. So, number 1, number of cells affected by the hyposegmentation. Kung more than 60% of the WBCs are hyposegmented, ibig sabihin true Pelger-Huet yan. Pag lesser cells, false. Okay? Pseudo Pelger-Huet. And then next, sa true Pelger-Huet, lahat ng WBC lineages affected. In pseudo Pelger-Huet naman, neutrophils lang. Yung mga mature neutrophils lang ang meron. Okay? And then, in true Pelger-Huet, ma-appreciate mo ang normal granulation. Okay? Halos ng mga WBCs. Sa pseudo Pelger-Huet, meron tayong hypogranulation. Next, kung merong hypo, meron din tayong hypersegmented. Ibig sabihin, it contains more than 5 lobes. And it is actually associated with megaloblastic anemia. Kung matatandaan nyo yung megaloblastic anemia, it is caused by the deficiencies of folic acid and your vitamin B12 or cyanocobalamin. So, meron tayong mnemonics na ho-ho para matandaan nyo kung ano ang meron sa megaloblastic anemia. So, we have hypersegmented neutrophils in first age. Next, yung letter O is ovalocytes. And then yung next set of letters, HO, is for Howell-Jolly bodies. So, para matandaan nyo ano yung mga features ng megaloblastic anemia, tandaan nyo tong mnemonics. Okay, balik tayo dito sa ating neutrophil hypersegmentation. So, aside from that, ano ba ang pathophysiology? Bakit dumadami yung lobes ng neutrophil nila? It is due to myelocathexis. Ano ibig sabihin ng myelocathexis? This is actually the cell retention in bone marrow. Kailangan nang lumabas ng WBC mo out of the bone marrow and yet, hindi lumalabas. So, ano ang consequence ng myelocathexis? So, pwedeng it can cause normal neutrophil production dahil normal naman, no? Normal naman yung number, pero hindi lang lumalabas. And kapag hindi lumalabas yung neutrophil out of the bone marrow, continuous pa rin yung segmentation of the nucleus. Kaya nagkakaroon ng hypersegmentation. So, kapag hypersegmented na, hindi na siya pwedeng lumabas out of the system due to the deranged morphology. So, naman, it is associated with another syndrome called WHIM syndrome. And WHIM syndrome is actually a mnemonics which stands for number 1, warts. Okay? Number 2, hypogammaglobulinemia. Ano ibig sabihin nitong hypogammaglobulinemia? Decreased levels of your gamma globulins or in the form of antibodies. Okay? So, bagsak ang mga antibody production mo. So, since mababa yung mga gamma globulins mo, hirap ka rin to fight off infections. So, may multiple infections ka rin due to bacteria and fungi. And lastly, yung last M is myelocatechesis. Again, your myelocatechesis is the cell retention in the bone marrow. Okay, next condition is Alder-Rayleigh anomaly, which contains the large dark staining granules. Saan nanggaling itong mga large dark staining granules? This is actually your waste products na pinroduce ng iyong lysosomes. And itong mga waste products na to, naiipon sa loob ng WBC. Hindi sila nadudurog completely. Okay? Ang mga waste products na to is what you call the mucopolysaccharides. And merong mga condition na nakakapag-produce ng or hindi nakakapag-degrade nitong mga mucopolysaccharides called your mucopolysaccharidoses. And this group of conditions, itong mga to, Hunter, Hurler, Sanfilippo, these are all associated with Alder-Rayleigh anomaly. Okay. Ano ulit ang mga dark staining granules na to? These are your mucopolysaccharides. And again, makikita in Alder-Rayleigh anomaly. Ano yung mga example ng mga condition na nagkakos ng ganitong anomaly? Your mucopolysaccharidoses such as Hunter, Hurler, Sanfilippo, yung mga yan. Next condition is Higashi Syndrome. Sa Higashi Syndrome, recall lang natin that the platelets and at the same time your WBCs are enlarged due to the abnormal fusion of the granules. And this is also an inherited disorder. Ano yung genetic mutation involved in this syndrome? Ang mutation is at the chromosome 1, lalong-lalo na in CHS1 LYST gene. And this mutation can cause lazy WBCs dahil nga sobrang laki nila and mabigat due to the fusion of the granules, hirap gumalaw yung mga WBC. So therefore, ang consequence niyan is the patient will have recurrent pyogenic infection. Paulit-ulit na bacterial infection. So, under microscope, ito yung mga fusion of the granules. So, ito yung nagpapabigat din sa WBC. So, hirap silang, dito, sobrang laki na fusion. Hirap silang gumalaw. So, tinatawag natin mga lazy WBCs. Next is may Hegelian Anomaly. Dito naman, merong abnormality in the myosin heavy chain. So, MH for myosin heavy chains. Para wag kayong magpapalito. Okay? And again, inherited disorder ito. And ano yung genetic point mutation niya? It is at MYH9 gene at chromosome 22. And this will cause your Dole bodies production in WBCs. And another problem is that it can cause macrothrombocyte o tinatawag natin giant platelets. So ano tong mga Dole bodies na to? These are actually accumulated RER o tinatawag natin rough endoplasmic reticulum. So na dapat wala na in mature WBCs. So the persistence of your RER, ito, halimbawa dito sa mature neutrophil na to, is what you call the Dole bodies. And madalas, associated sila with may Hegelian Anomaly. And yung sa may Hegelian Anomaly, anong abnormality ulit? MH, myosin, heavy chains. Next disorder is CGD. CGD stands for Chronic Granulomatous Disease. And ano ang nagkakos ng granuloma dito? This is caused by the inability of your WBC to produce enzymes or mga compounds to fight off infection. Ano ba yung mga compounds na yon? Your superoxide and ROS or reactive oxygen species. And bakit nga ba walang itong mga compound nito? Due to the absence of the NADPH oxidase enzyme. Okay? Absent ka nito, so wala ka na produce na mga compound to fight off your bacteria. And ano ba yung process of degradation of bacteria with the help of this compound? The process is what you call the respiratory burst. Respiratory burst ang tawag dahil kailangan niya ng oxygen. Okay? Kaya isa sa mga materials or ingredients to produce this type of compounds is oxygen. Okay? And ayun nga, so dahil hirap ka gumawa ng mga ganitong compounds, hirap ka rin mag-fight off ng mga bacterial infection. So therefore, meron kang incomplete scarring. This scarring is called your granuloma. Okay? So ang pinakaunang problem mo dyan is the NADPH oxidase causing the inability of neutrophil respiratory burst brought about by the absence of superoxide and ROS, therefore producing your granulomas. So under microscope, ito yung granuloma na sinasabi natin. Okay? Itong abscess na to, okay? Actually, meron pumupunta naman na mga WBC. Pero, ini-enclose lang niya. Kasi hindi niya kayang patayin totally yung bacterial content ng abscess. So, therefore, itong formation na to, no, abscess na encircling with WBC is what you call the granuloma. Okay. We have laboratory tests for CGD. This is what you call the nitro-blue tetrazolium reduction test. Anong ginagawa natin dito sa nitro-blue tetrazolium reduction test? So first, i-expose mo yung mga normal WBC with your reagent, okay, which is has a yellow compound. Kapag normal, no, yung ating WBC activities, so magkakaroon ng respiratory burst, magkakaroon ng reaction of your nitro-blue tetrazolium with superoxide and your ROS, forming your formazan compound. And formazan compound will convert the yellow color into dark blue color. Kapag walang oxidation, no, ibig sabihin walang respiratory burst na nangyari, mariretain ngayon yung color yellow as final result lalong-lalo na in CGD. Di ba sa CGD, walang respiratory burst. So, yellow pa rin yung color niya at the end of the laboratory test. So, under microscope, this is the positive result. Again, what is the compound na nagpapa-blue dun sa color ng nitro-blue tetrazolium? It is the formazan. Dito naman, medyo hindi nyo ma-appreciate yung yellow kasi medyo orange pa siya, no? This is a negative result. So, kapag tetrazolium negative, ibig sabihin, meron siyang CGD. Next is leukocyte adhesion disorder. Kasi one of the function of your WBC is to adhere with endothelial cells. Ano ba ibig sabihin ng endothelial cells? These are the lining of your blood vessels. Okay? Kailangan niya mag-adhere doon to be able to travel along the bloodstream. Okay? So, we have three types of LAD or leukocyte adhesion disorder and depende kung anong genetic mutation. Kapag LAD1, ang mutation niya is exon 5 to 9 and the defect will affect the beta-2 integrin receptor, which is a protein for one of the proteins for the adhesion to blood vessels. LAD2 naman, mutation in SLC35C1, which affect the fructose transportation. And lastly, your LAD3, mutation of your kindlin 3, which affect the activation or yung paggising ng WBC, no? Leukocyte activation. So wala tayong choice but to memorize these numbers and terms. Wala akong maisip na mnemonics. Okay, next naman, myeloperoxidase deficiency. Myeloperoxidase deficiency is solely found in primary granules lang ng mga neutrophil plus lysosome of your monocyte. So, it will affect the activity of these two type of WBC only. Okay? Para saan naman si myeloperoxidase? Kamukha siya ni ROS and superoxide dahil it will act as compound to fight off bacteria. Okay? So, magpapalito with the two conditions, CGD and myeloperoxidase. Another importance of your myeloperoxidase, this is an enzyme which produces your hypochlorite and hypochlorous acid, which is supposedly affects the membrane of the bacteria. Diba ang ating bleach is made up of chlorine? So, ito rin yung kamukha niya. No? Ito yung the same enzyme which attacks or which degrades the membrane of the bacteria. Again, this is an inherited disease. Ang mutation niya is at MPO gene on chromosome 17. Next disorders or next qualitative disorders are your lysosomal storage disorders. Again, ano nga ba ang silbi ng lysosome? This is for the degradation of your waste products. Kung may abnormality with your lysosome, hindi mo nade-degrade ng maayos ang waste products mo, naiiwan lang sa loob ng cell yung mga waste na to. Okay? And most commonly mechanism of associated with lysosomal storage disorders are enzyme deficiencies, and enzyme is supposedly for the degradation of the waste products. Ano ang mode of inheritance usually kapag enzyme deficiency? Back in cytogenetics, di ba? Kapag deficient protein, ibig sabihin recessive in pattern. So, almost all autosomal recessive in pattern yan. As a result, yun nga, mag-accumulate yung mga waste products natin such as your glycosaminoglycans or mga lipids natin. Example of this, the most common is Gauchers disease and your Niemann peak disease. So, discuss natin tong dalawang ito. Unahin natin si Gauchers disease, which is, again, the most common type of lysosomal storage disorder. Ano ang deficient in Gauchers disease? It is the enzyme called beta-glucocerebrosidase, which is found in chromosome 1. Kapag wala ka nito, naiipon yung compound called glucocerebroside. So, ang magpapalito kung alin ang deficient and anong compound yung nag-accumulate. Remember, lagi, no, kapag ganitong mga disorder, enzyme ang kulang. So, ASE yung ating suffix in enzyme. Okay? So, huwag magpapalito sa dalawa. And to diagnose your Gaucher's disease, you have to fulfill these three criteria. The triad of hepatomegaly, which is the enlargement of your liver, plus the presence of your Gaucher cell in the bone marrow, and the increase in serum phosphatase in liver, yung mga ALP, 5-NT, and GGT. Okay? So, anong itsura ng Gaucher cell in bone marrow? It is described as crumpled paper appearance. So, ito daw yung parang nilukot na papel. No, yung lalo na sa cytoplasm ng mga WBCs. And we have special laboratory tests for Gaucher's disease. Number 1, yung ating chitotrosidase is a biomarker for screening for the accumulation of the glucocerebroside. Paki-correct na lang yung ating handout. Dapat glucocerebroside yan. Etong chitotrosidase is for the accumulation of this compound, while the PAS or periodic acid shift is for the enzyme. Okay? PAS negative sa Gaucher kapag walang presence of your glucocerebroside. Kasi kailangan may presence of this enzyme in order to become positive in PAS stain test. So again, ito yung mga accumulation of the glycosaminoglycans. So mukha silang mga crumpled paper under microscope, supposedly. Okay, next naman is Niemann-Pick disease. Ang deficient natin dyan, again, enzyme dapat yan. So ASE. Okay, sphingomyelinase. Ang accumulated is the protein, sphingomyelin. Okay? And then, ano ang tawag naman sa cell? From the name itself, Niemann-Pick cells. Ano ang difference ng Niemann-Pick cells sa Gaucher cell? Ang Niemann-Pick cells has foamy cytoplasm. Bakit foamy? Mukhang bula, no? Kasi it has lipids, no? As compared with your Gaucher cell which has glycosaminoglycans, dito naman mga lipids ang meron sila. Diba? Again, lipids are stain resistant. So, walang kulay under microscope supposedly. So, yan. Kung makikita nyo, no, hindi sila nag-take up ng stains. So, again, we have lymphocyte disorder na. So, kanina, no, mga general WBC, ano talaga, pang neutrophil and monocyte problem. So, dito tayo focus din. Mag-lymphocyte disorder din tayo. And again, we have two types of lymphocyte. Generally, we have T cell, B cell, and also NK cell. Pero hindi madalas sinasama yung NK cell kasi kokonti lang sila in your bloodstream, no? Pinakamarami pa rin dyan is your T cells. Okay? So, umpisahan natin with ano ba yung mga disorders affecting your T cells. So, we have your Gauchers Syndrome. And then, pag B cells naman, X-linked agammaglobulinemia or Bruton's disease or Bruton's agammaglobulinemia. So, pare-parehas yan pagdating sa books ninyo. Kung magbabasa kayo ng book. Okay? Pero, practicality, no? Practicality-wise, wag na kayo magbasa sa ngayon. More on handouts na kayo. Kasi supposedly, nagbasa na kayo ng libro during your academe days. And then, we have combined T and B B-cell problems, which involves your SCID or severe combined immunodeficiency and Wiskott-Aldrich syndrome. So, babalikan natin yan later on. So, unahin muna natin yung ating Gauchers syndrome. Sa Gauchers syndrome, again, ang problem mo dito is your T cells. Bakit nagkakaproblema ang T cells? Kasi the pathophysiology of the Gauchers syndrome is a thymus problem. Kung maalala nyo, di ba, dito lang ang site ng differentiation and maturity of your T cells. Pero ang T cells is majority produced in your bone marrow. Kung maalala nyo yung ating rule about T cells are produced in the bone marrow. Ang maturity nasa site of your thymus. So kung wala kang thymus, walang mature T cells, nagkakaroon ng Gauchers syndrome. But not only that, marami ding problema sa Gauchers syndrome. So, alalahanin natin yung ating mnemonics na catch-22. So, ano ibig sabihin ng catch-22? Number 1, i-consider natin, no, lahat ng problema ng Gauchers syndrome nasa gitna. Kung malala nyo yung thymus, di ba nasa, chest area yan, katabi yan ng lungs. So, meron tayong problema in thymus. Meron din tayong problema in the heart. Nasa gitna yan, right? Meron tayong problema sa face, abnormal facies, no? Hindi pantay yung facial features. Yan. Thymus, cleft palate, no? Nasa gitna yung bibig natin. Okay? And meron tayong decreased calcium production brought about by the problem of your thyroid naman. Which is, nasaan ang thyroid glands nyo? Di ba nasa gitna din? Right? And, yun yung sinasabi ko, lahat ng problema ng Gauchers nasa gitna. So, iisipin nyo lahat ng mga organs na nasa gitna. Thymus, thyroid, heart, okay? Cleft palate, and due to your thyroid problem, bumababa ang calcium. Okay? And anong chromosomal number affect ang genetic mutation ng Gauchers? Nasa 22. Kaya ang mnemonics is catch-22. Okay? Kung gets nyo tong mnemonics, wala tayong problema. So, ito yung picture ng abnormal fascie in Gauchers syndrome. And again, sabi ko nga, hindi pantay yung facial features nila. Okay? Yung side na to, no, medyo slanted yung mata. Dito naman, pabilog. So, kung ma-appreciate, obvious naman yung yung difference ng right side sa left side. B-cell problem naman tayo. Sa B-cell problem, again, nandito yung Bruton's disease. So, from dun sa ating letter B, okay? So, pang B-cell yan. Okay, Bruton's. And, another name is X-linked agammaglobulinemia. Kasi, X-linked inheritance siya. So, more common siya in what gender? Male or female? Sa mga male. Kasi, XY ang male, right? Kung defective yung X ng XY, walang magsisave dun sa X. Kaya mas prominent yung disease dun sa mga males. So, di ba, ang ating female X, di pantay ang aking word. Sorry Dito ang ating female, right? Kung defective yung isa, may magsisave na healthy X. So, hindi prominent yung B-cell disease sa mga females. As compared sa mga male, kung defective yung isa, hindi masisave ni Y yung defective X. Kaya full-blown yung disease sa mga males. Okay. And ano ang genetic mutation ng mga X-linked agammaglobulinemia? Nasa BTK gene. Okay, BTK gene is expressed in low amounts. So, causing the poor B-cell development or the differentiation or the maturity of the B-cells. Okay, dito naman tayo sa mga combined T and B-cell problem. Unahin natin yung severe combined immunodeficiency. We have two types of this. So, we have X-linked. Again, pag X-linked, ang mas problema din natin dito, yung mga males. Kasi mas full-blown dito. Ang less common naman is your adenosine deaminase deficiency. Okay? Paki-correct na lang, no? Accumulation of adenosine deaminase ito. Tapos, ang genetic disorder naman with X-link is the receptor called interleukin 2. The difference between these two disorder is the manifestation. Sa X-linked acid, absent ang NK, decreased T, and dysfunctional ang B cell, although in normal numbers. Sa adenosine deaminase naman, lahat, no, NK, T, and B cells are absent or depleted. Next type is, again, combination of our T cell and B cell problem. Wiskott-Aldrich syndrome. Sa Wiskott-Aldrich syndrome, ang absent is their WAS protein gene or WASP. And this gene is responsible for the migration, adhesion, activation of your both T cell and B cell. Okay? And kailangan ma-fulfill niya yung tatlong criteria to be diagnosed with Wiskott-Aldrich syndrome. Kailangan niya ng yung platelet count is mababa or thrombocytopenia, immunodeficiency, mababang levels of your immunoglobulins, and eczema, which is a skin condition. So, ang ating mnemonics dyan is TAI. So that's it for our part 1 of this session. Break muna tayo. No? Magmuni-muni muna. Try natin intindihin yung previous information before you proceed to the next videos. So make sure to go back to this channel for the part 2 of our lecture session.